My name is Carrie Lidbeck, and I'm part of the Disease Prevention and Response Division within Spokane Regional Health District. Joining me today are my coworkers Betsy Bertelson, a nurse and epidemiologist, and Kylie Kingsbury, the lead for our Immunization Assessment and Promotion Program. We'll be recording today's webinar so that it will be available to anyone who wants to view it again or to be able to share with those who weren't able to attend today. You can see that we have a fairly full agenda for today's hour, but there will be time at the end of the presentation for you to ask questions of Dr. Opel. Today's learning objectives are as follows. And before we get started, I'm going to perform a bit of virtual housekeeping. In order to make this experience as interactive as possible, there will be times when you'll be asked to respond to a question, and you can use the chat box for that. Someone will also be monitoring this chat box for questions later from participants. Please keep your phone and computer microphone muted in order to eliminate the feedback, such as what we heard earlier. And after the webinar, we're going to share a link in the chat box that will take you to an evaluation, and we really will appreciate any feedback that you can provide for us. So finally, I just ask that you be fully present and participate in the process. So let's get started. We're pleased today to have Dr. Douglas Opel with us. He is an associate professor of pediatrics at the University of Washington School of Medicine. He's also the director of clinical ethics at Seattle Children's Hospital. And I'm now going to hand over the controls to Dr. Opel.
Thank you, Carrie, very much. It's really a pleasure to be here. I want to make sure, Carrie, you can hear me at least, and hopefully everybody else can. Is that true?
I can hear you very well.
Right. I assume then everybody.
Type in the chat box if anyone is not able to hear.
Great. Well, thank you, Carrie, and all the organizers for this webinar. It's really a pleasure to be here. I have given a talk like this in a more interactive setting. For instance, at last year's or actually this year's VAX Expo. It feels like last year. It was only in May. I know it's not as easy to be as interactive through, the internet and on a webinar. We're going to give this a try. I think the topic like this about dilemmas we face when parents refuse vaccines is best when we actually have a discussion and we share with each other our own experiences and perspectives. So to the extent we can do that, albeit somewhat limited because this is a webinar, please do use the chat box to provide your thoughts along the way. And I'll pause at several points to ask for more explicitly, simple yeses or nos about how you feel about certain things, but you can certainly elaborate in the chat box if you feel free to do so. And we'll routinely be watching that chat box. And in addition, we'll leave a good chunk of time at the end of this hour so that we can hear from you as well. So let me get this started by presenting a case. Advance the slide here. Okay, by presenting a case that illustrates this dilemma nicely, where parents refuse or delay vaccines. But before I present this case, let me say a first sort of few things about this case. First, it's a real case from my own clinic that involved me as the pediatrician. I've modified it slightly to protect confidentiality, but part of my rationale for using a real case is because I wanted to, convey the genuineness and authenticity of this issue that many of us feel, unfortunately, consistently these days. Second, I realize not all of you are pediatricians on the call, and this may not resonate as easily, but I do encourage you to think how this issue of vaccine refusal most often manifests for where you work. And I think you'll see that while the context might change a little bit, the underlying issues remain the same. So here's the case. You're seeing a 6-month-old boy for his health supervision visit in your primary care practice. And this boy is completely unimmunized at the parent's request despite your efforts. The parents remain staunchly against DTaP. And it's April 2012, and there is a pertussis epidemic. You can consult the DOH web page for current epidemiologic data about this epidemic, and you see that there have been 150 cases of pertussis in children less than 1 year of age in your state, and over 2,000 cases total. I'm having trouble advancing the slide at the moment. Here we go. Okay. You explain the current risk to the parents of getting pertussis, of their child getting pertussis, and the potential consequences of this disease. And as a result, you strongly encourage them to immunize their child. Despite that, they remain steadfast in their refusal. They strongly believe and communicate as much that the risks of immunization outweigh the benefits and that their child's naturally strong immune system will protect him. So that's the case, and while I'm not hoping it sounds familiar, unfortunately, I think in this day and age, it likely does. And I'll also say, though this is the case about pertussis, and from 2012, I could have easily exchanged pertussis for measles and 2012 for 2019, given the recent measles outbreak in Clark County and other places in our state. So I think this type of encounter, unfortunately, is becoming more and more familiar. So really the question that, really as the foundation for this whole talk is this one: what would you do? What would we do at this point with these parents? And at the time, I saw at least 3 options. Here's the first. One option was to call CPS, Child Protective Services, because this is medical neglect. At the time, as the case mentioned, we were in the middle of an outbreak, and this parent is deliberately choosing to keep their child unprotected against the disease causing the outbreak, despite the availability, as we know, of a safe and effective vaccine to prevent it. So on some level, it was hard for me not to get past this point. How could this not be neglectful? Another option was this: all right, maybe don't call Child Protective Services, but tell the parents that you can no longer be their child's doctor because of their refusal to accept vaccines. And the argument for this option is simply, look, there are a few things that are central to our identity as pediatric providers, public health professionals, and one of them is practicing preventive care or promoting the public's health. And I know no better way to do that than through vaccines. So if the parents and I can't agree on that, perhaps they need to find somebody else. A third option is this: all right, maybe not call Child Protective Services, maybe not fire the parents from my practice, accept their continued refusal, but explore alternatives with the parents, like ensuring everyone at home is up to date on Tdap, and tell them you want to continue discussing immunizations and you'll do so at the next visit at 9 months. This is the least confrontational option and perhaps most accommodating, but also perhaps represents an opportunity to help parents change their mind over time. And there are probably other options that maybe some of you are thinking about or even have invoked at some point along the way. And it's at this point that I'm going to pause explicitly and ask you all for your input. And you can put in the chat box simply a number, 1, 2, 3, or 4, based on what you think you would do if you haven't encountered a situation like this, or what you have done if you have encountered a situation similar to this. And if you are feeling comfortable and you want to unmute yourself, you can feel free to elaborate on why you chose what you did and how it went. So I'm seeing some 3s and 2s at the moment. Mostly 3s. So that, yeah, as they're coming in, it seems most would not do the first 2 options, which are the more sort of intrusive. And most are settling on number 3. All right, what we're going to do is go through each of these options and talk through their, how justifiable they would be. And we'll start with option 1, particularly because this didn't seem to be a popular option. So for those of you who didn't choose option 1, maybe because it seems too intrusive, or maybe it's unrealistic or really too fringe, let me highlight this recent article in the academic literature in a reputable journal of Pediatrics, just a few years ago, written by some respected clinicians and philosophers who argue for this very option. They say, and I'm going to underline this, the parent remains unpersuaded, their informed refusal becomes child neglect, and it is a strict legal obligation to report child neglect to the local Child Health Protective Services agency. So this is very much something that are at least on a few people's minds. And I'll also highlight this newspaper article from March that I was interviewed for, in which this question really took center stage when Oregon doctors publicized the case of a 6-year-old boy, some of you may have heard of this, who spent 8 weeks in intensive care because he got tetanus from his family's farm. And his parents declined to further vaccinate the boy against tetanus at the end of his hospital stay on discharge, even though he was going back to the same farm and the risk of contracting tetanus again was just as high as before he was admitted. So this question is very much, I would argue, on people's minds, and I think people are beginning to entertain this more seriously. So let's think through this and explore the appropriateness of this option. So to do that, let me back up a bit and be explicit about the ethical issue here. Parental refusal of recommended vaccines for their child really illustrates a classic ethical tension in public health. On the one hand, you have the value of individual choice or parental authority. On the other hand, you have the value of common good or public health. These values are competing. Favoring one undermines the other. So they're in constant tension, and how to balance them, protecting individual choice and the common good, is really an eternal struggle. So we as public health professionals and practitioners really are often at the center of this balancing effort. When a parent refuses to comply with our vaccine recommendations, as the case illustrated, we are at the front lines of how to balance this. We have to decide whether to accept that parent's refusal and therefore respect their choice, or to say, no, mom or dad, you can't make this decision, and it's for the good of your child's health and the health of the community. We have to immunize your child, and therefore prioritize the common good or the public's health in addition to the child's individual health. Option 1, which involves calling Child Protective Services to report the parents as neglectful in order to immunize the child, is in essence an argument that the common good really should be favored here at the expense of individual choice. So is that justifiable? Well, to answer this, we have to review why we give parents authority in the first place to make decisions for their children. And to be clear, we do. Under U.S. law, parents are empowered to make healthcare decisions on behalf of their children. This is based on the presumption in U.S. law to respect parental authority and family privacy. In addition, it's a central societal value in the U.S. to allow parents, or to give parents the freedom to raise their own child with the morals and principles of their choosing. As a result, parents are really generally given wide discretion in their decision making because they know their child best and they can weigh competing family interests best. So the justification to intervene against the parent's decision, however much we disagree with it, consequently requires a high threshold, and I would argue rightfully so. That said, there is a threshold. Parental authority is not absolute. Parental decisions are not respected if they put a child's health, well-being, or life in jeopardy. And sometimes it's obvious to us as clinicians or public health professionals when this threshold is met, such as a parent physically abusing their child. That's sort of an obvious one where we can easily say and know that we can intervene and say, no, this is not tolerable. But other times it's not so clear, such as, in the case I presented to you when a parent, refuses vaccines for their child. How do we decide then? I think the question is whether we've met this threshold. So one of the learning objectives was about this principle, the harm principle. So this is an important takeaway that I hope sticks with you by the end of this talk. The harm principle is instrumental for us in our determinations of whether we've reached this threshold and feel justified in intervening against the parent's decision. And this is the harm principle. Does the decision made by the parent significantly increase the likelihood of serious harm to their child as compared to other options? And I'm going to let that sit with you because it is a mouthful. Does the decision made by the parents significantly increase the likelihood of serious harm to their child as compared to other options, namely what the clinician wants to do? This is the question I would argue we should ask ourselves in any scenario where the parent isn't wanting to agree with what we want to do in a medical context. It doesn't have to be vaccine related. But this is, if we can answer yes to this, we should be justified or feel justified in seeking state intervention, calling Child Protective Services to override the parent's refusal. And I want to be clear here, if we answer yes to this, that doesn't mean we as the provider or public health professional has authority to do something against the parent's will or consent. It gives us justification for calling Child Protective Services, and they will solicit the court to make this decision definitively. But the reason why this harm principle is the relevant question for us to ask is because this is what judges use. When CPS solicits the court, this is the question the judge is going to be asking him or herself to whether he takes away parental decision-making authority. So let me just tease out the reasons why the harm principle is the right question to ask in these scenarios. Because there is, has sound legal and ethical bases. Its legal basis is in both constitutionally sanctioned police powers granted to governments to protect the public's health, welfare, and safety, as well as the parents' patria doctrine, which gives the state the authority to protect and care for those who cannot care for themselves. So courts use this doctrine, as I said, to justify intervention when there's evidence that parental actions or decisions are likely to harm a child. Now, the ethical basis for this exercise of police powers and the parents' patria doctrine was argued by this philosopher named John Stuart Mill, who said the only purpose for which power can rightfully be exercised over any member of a civilized community against his will is to prevent harm to others. His own good, either physical or moral, is not a sufficient warrant. So those are the bases for the harm principle, and let's return to it again here, because what I'm emphasizing now in this harm principle are two key sort of concepts that the harm principle asks us to consider, and that's regarding the likelihoods and harms. So it forces us, as we ask this question, to quantify these risks and harms. And this is because, as we talked about before, the threshold for intervening against parental decision-making authority isn't something we ought to take lightly. It needs to be at a high level, given the, reasons I mentioned before for respecting parental decision-making. So we need to prove to ourselves, with a reasonable amount of certainty, that the likelihoods and the harms are high enough. So it must be a significant risk of serious harm, not a minimal risk of a minor harm before we feel justified. And importantly, we have to compare those risks and harms of what the parent wants to do with the risks and harms of what we want to do. It's very much a proportionality compared to other options. So what I'd like to do is kind of operationalize that harm principle for this case. It's not always easy to do this calculation and sort of entertain this question on the fly at a busy clinic day, for instance. But in this case, we could do that, and there is a reason to pause, in taking care of this kid, to sort of think through this a little bit more deliberately. So I wanted to illustrate how that might be done. And I'll say the Department of Health really makes this easy in the context of this case because, as many of you likely remember, during that pertussis outbreak, they had up-to-date weekly information put on their website for all to see regarding the risk of the child contracting pertussis. So this is what was on the web page in 2012 at the time this child was being seen. And we see the cumulative incidence over the entire one-year span of the pertussis epidemic in 2012 by county for all ages. And cumulative incidence, as you remember, is the probability of developing disease over a stated period of time, and it's a reasonable estimate of risk here. So what I'm showing you here is the overall incidence down there in the corner, with 72.1 per 100,000 in the state. And then where I was practicing in King County, the overall incidence of pertussis for all ages was 40.1 per 100,000. So this data begins, while not perfect, an idea of the risk of pertussis, at least in the county in which you might be practicing, and for King County was 40.1 per 100,000, and converted to a percentage, it's about 0.04% risk of contracting pertussis. Now you might say, well, I don't really care about the incidence by county as much as I do incidence by age, and that would be a really important point here, because the most susceptible persons to contracting pertussis and having complications from it are those who are very young, under 1 year of age. So the incidence in that age group we can also find on the DOH website, and you see it here. It was much higher, as you might have suspected, 428 per 100,000, or about a 0.428% risk. So a 10-fold increase from the incidence in all ages in King County, but still, I would argue the absolute risk is still quite low, less than 1%, despite it being an outbreak. But risk is only one of those things in our harm threshold equation. Remember, harm is relevant too. So what is the harm associated with pertussis if a child would catch it? Well, we know this from prior published data. About half who get pertussis are hospitalized. Half of kids who get pertussis are hospitalized, and of those, 25% have major complications: pulmonic, encephalitic, nutritional. 1% or less will die. So it depends on what we're talking about as serious harms. Certainly those who have major complications or worse would be considered to be serious. Some may even consider hospitalization to be serious. Certainly there is risk, or there are many harms that a child could suffer if contracting pertussis. Because this is a proportionality that we have to consider risks and harms in, we need to think about risks and harms of what we want to do with a child getting immunized with DTaP. And so it's important to quantify those two, the risks and the harms. And most of the harms would be minor, like fever. There may be some more major harms: hypotonic, hyporesponsive episodes, seizures. But the risk of all those are fairly small about the risk of, frankly, contracting pertussis, as we talked about, less than 1%. So let's return to this harm principle and specifically this question, and try to answer it now, given that context and the risks and harms we just reviewed. Does the decision made by the parents, in your opinion, significantly increase the likelihood of serious harm to their child as compared to other options? Does a less than 1% chance of getting pertussis, even though it is an epidemic, with about a 25% chance of suffering major complications if a child does get pertussis, compared to a less than 1% chance of suffering any adverse effects from the vaccine. Does that meet our threshold of a significant risk of serious harm? And that's a question for all of you. I think we will all probably come to a different conclusion based on how we're thinking through this. And here's the tricky thing with this harm principle is it's not, while it does more to help us be objective, it's not entirely free of subjectivity. What is a significant increase and what is a serious harm? As we've been talking about, there are different interpretations of that. So we may come to different answers when we think through this ourselves. In my opinion, I think it's undeniable that there is some increased level of risk, and if the child gets pertussis, some level of harm to that child. I think all of us would agree with that. In my opinion, though, I think it's hard to argue that a less than 1% level of risk constitutes a significant risk, and that the level of harm is not serious enough to justify intervening against a parent's wishes. But that's my opinion. That makes calling CPS less justifiable. But again, I encourage you to use the chat box. Do people agree with this? My opinion on answering this harm principle for this particular case. You can answer yes or no in the chat box. My suspicion is, because many of you, from what I recall, didn't choose this option, that I suspect you likely do agree with it. Part of my reason, though, rather, and not to have us all come to consensus, but more that to articulate how we can justify coming to this decision, and it's really through use of the harm principle and understanding the bases for this harm principle. So I'm going to move on to some data that supports sort of this option being less justifiable. We looked at CPS policies and court opinions recently, and most agreed that this option, and our determination that this option is less justifiable, agreed with that determination. So some state agencies, for instance, we found screen out reports solely based on failure to vaccinate. In fact, Michigan does that. And other states like Oregon and Illinois codify that vaccine refusal does not constitute medical neglect. So some state CPS agencies have already started tackling this issue, probably because they've gotten inquiries from folks like us about how they would handle it. And so they've been explicit on web pages and things about what they would do with vaccination. And you can see here several states just sort of screen these out. When we searched, we went a little bit further. When we searched court opinions over a 110-year period to see how many cases had vaccine refusal as the primary reason in a medical neglect proceeding, we found only 9 cases in 5 states. 5 of those cases were adjudicated when non-medical exemptions didn't exist, were not permitted. So all of those, not surprisingly, were considered to constitute neglect. But of the 4 remaining cases, only 1 occurred in the last 20 years. And vaccine refusal did not constitute neglect, or was considered neglect only in the absence of a sincere religious belief. So after doing this sort of perusal of adjudicated cases, I think while we can't conclude anything definitively given the small sample size, I think what I have sort of come away with is that even if CPS did act on a call from us about a parent's refusal to vaccinate their child, most recent court rulings, albeit a small sample size, suggest that it's not clear that parents would be found neglectful anyway. So before we leave option 1, I think it's important to highlight 2 questions that were certainly raised for me. The first is this one. Well, if we can't make this case that this is neglectful or constitutes child neglect to take away enough to take away the parent's decision-making authority during an epidemic or an outbreak, are we ever justified in intervening against a parent's decision to not immunize their child? this was something certainly I reflected at the time. I felt like I could make this case, especially at that point when there was this outbreak going on, but in the end, I didn't feel as justified in doing so. And so it led me to think, well, when might I ever be justified if I can't do it now? And I think the answer to this is there are going to be times when we are justified in taking away a parent's decision to not immunize their child. But I would argue that the circumstances are pretty infrequent. So you can imagine a child who's not otherwise healthy, but has an underlying medical condition. Maybe they're an extremia, they have bronchopulmonary dysplasia, et cetera, that might increase the risk of harm that they would suffer from getting a vaccine-preventable disease. So again, it links back to the harm threshold, but you can imagine scenarios, clinical scenarios, where the risk of harm could be reaching that threshold given, for instance, a patient's underlying condition. But I think those circumstances, though exist, are likely to be infrequent. The other question that came to mind was, well, what about the potential harm this parent's refusal creates for the community? I mean, it's important for us to think about this. Should parental authority be favored over the right of others to be free from unnecessary exposure to vaccine-preventable disease? This doesn't seem right for us to answer yes to this. I mean, many of us are in our roles because of wanting to promote public health, and so this is an important question for us to sort of think about. And again, my answer to this is no, we shouldn't favor parent authority necessarily, but the better question here is, what level of infringement on individual choice is justifiable to protect public health? Okay, so restrictions of civil liberties is something we can do to protect a common good, but that restriction needs to be reasonable based upon both the scope and nature of the public health threat and the degree of infringement on individual rights. Okay, we won't want to institute a quarantine for something that's a minor public health threat, for instance, because of the degree of infringement that has on individual rights, and it's not reasonable based on a minor threat or something of that nature. So we need to have it be reasonable. So it's what level of infringement is justifiable. And this gets into the policy realm then on how to answer this, and it's led to several professional organizations speaking out about how they think this problem of parental refusal ought to be dealt with at the policy level. And many of you know that professional organizations such as these four have come out publicly to favoring the strategy to eliminate non-medical exemption, the most recent being the American Academy of Pediatrics. And this has, not been controversial on some level, but others have found it controversial because of its perception that it's really intrusive on individual choice and to remove the ability to opt out. Did I hear that there's a question from somebody or no?
Yeah, Dr. Opel, there's a comment in the chat box from Eric.
Yeah.
So, did you want us to read that, or do you want to just respond to it?
Yeah, so I'm seeing it now too. So Eric, you're right. It seems in ethics that is situational, depends on the level of absolute risk it has. If we had smallpox, major, or Ebola with a 20 to 30% mortality and a parent refuses child vaccination, maybe then the risk is great enough to call CPS. I think that's absolutely right. And it is very much situational. It has to do with, frankly, the person in front of you and the situation they're in front of you, whether they've met this threshold of risk and harm to feel justified. And so it's difficult to impart generalities, therefore, as part of maybe what you're saying. But by using a common framework like the harm principle, it'll help us dealing with those specifics that are involved in any particular case. Thanks for commenting on that. So let me just end option one and this policy issue by saying that ultimately this is a question of balancing competing values that we talked about of individual choice and the common good, and namely what restriction of choices we talk about is reasonable based on the public health threat of being unimmunized. Now, if we view policymaking as not only what reflects good evidence or the best evidence, but also a reflection of societal values, we see how imperative it is for us as professionals to make our values known to legislators and policymakers. So if policy was just about evidence, we would require everyone to be immunized and immunized on time, right? Because of the overwhelming evidence for immunizations. But it's not just about that. It also has to represent societal values about choice and that value, as well as the common good and where that balance lies. So people have sort of taken advantage of this issue of values, and for instance, the parents and organizations they belong to that really have problems with vaccines have been very vocal to try and influence the conversation about their concern about individual choice. I think it is just helpful for us to remember we have a voice too, and we need to empower parents who are accepting of vaccines to be empowered too to make their voice known and voice the importance they see in also protecting public health. And recent Washington state policy, as you all are aware, and legislation really provided a snapshot of how this balance between these convening values sort of played out and where that balance currently lies. So House Bill 1638, which ultimately was what was signed into law by Governor Inslee, removed personal belief exemptions from MMR only. So it attempted to push the balance back towards prioritizing the common good by removing personal belief exemptions. But it wasn't as successful at pushing it all the way or more towards the common good as Senate Bill 5841 was trying to do, which was going to removing personal belief exemptions from all required school entry vaccines. So that failed, and I think it failed because, again, it seemed to be or was perceived to by legislatures and their constituents to be too much favoring common good at the expense of individual choice. So what we were left with, or what could have ultimately did pass, was a little bit more restrictive version of that, of only removing the ability to opt out from MMR only. So this is currently where this balance lies in our state, and each state is different. Some have been more successful at this than ours, but it's helpful to know in our state how we're attempting to balance this. So that's all I want to say about option one. It is an important one to review because I think it's an up-and-coming option that more and more are entertaining from the pediatric and public health side. Let me move to option two, firing the parents from your practice. So some of you picked this option, and I wanted to start with this clinical report from the American Academy of Pediatrics, really that gives voice to this option. So it says here in the box, nevertheless, the individual pediatrician may consider dismissal of families who refuse vaccination as an acceptable option. So this is very much, again, something in the mainstream. Now, there are arguments for and against this. And part of what I want to do is really just lay these out so you can decide for yourself where you fall on this issue. So 4 arguments for firing parents. First one is, look, unimmunized and underimmunized children pose some increased risk of harm, not only to themselves, but transmitting disease if they were to get it to others. And keeping unimmunized kids in our practices means they are in our waiting rooms, sick potentially, and exposing others. And that's not fair to our other patients. Immunizations are the standard of care. I mean, this really gets at our generally strong beliefs in the science supporting the safety and efficacy of immunization as a standard component of pediatrics and public health, and providing preventive care, which immunizations is central, is so integral to many of us as pediatricians and public health professionals that not doing so is asking us to act contrary to these beliefs. And lack of trust undermines our relationship with parents. If a parent can't trust us on this issue, what will they trust us on? I mean, trust is so integral to the doctor-parent relationship that lacking it on this issue seems to compromise the whole relationship. And then fourth, dismissal policies send a powerful message about the importance of vaccines. So this may not only change some parents' minds, but given the clear conviction underlying it, really can potentially strengthen therapeutic relationships over time. So those are generally the four arguments for firing parents, and those may resonate with you. There are also arguments against firing parents, and I have 5 of those. First, vaccine hesitancy is a modifiable behavior. We know this from empirical evidence that parents change their mind about vaccines. So ending a relationship, firing them if they don't comply immediately, therefore can be counterproductive because it leads to missed opportunities over time to change their opinions about immunizations. Second, it disregards parental values, and the argument here is that maybe respectful exploration of value differences between a provider and a parent is maybe more productive for the relationship and more rewarding for the parent and provider than severing that relationship. And given those first 2 arguments, it takes time to, talk about a parent's hesitancy and to talk about their values. In fact, considerable time and resources, often uncompensated, and they can be emotionally and cognitively draining. So practices that fire parents before having these conversations really essentially redistribute those conversations, practices who do accept these parents, and also then redistribute those burdens, and that really isn't fair. Fourth, firing parents doesn't likely decrease a child's transmission risk elsewhere. So it does nothing to decrease this risk in other venues the child visits, like daycare or school or church or the grocery store. It may actually increase the risk of transmission because it potentially clusters these unimmunized children, as we talked about in the redistribution argument, into a few practices. And then lastly, there are less drastic alternatives that exist. Like we could sequester unimmunized and underimmunized kids in a separate waiting room, for instance, rather than firing them altogether as a way to decrease transmission risk. So again, you yourself have to weigh these arguments for and against and ultimately decide where you land on them. My personal opinion is that the benefits of keeping these families in my practice outweighs the risks, and therefore I do. But I would love if you could use the checkbox to say, maybe just for or against firing. There were a few that I think chose this option, and potentially for the reasons I mentioned on the previous slide. But if you would like to use the checkbox and provide reasons for why you are for or against, that would be good, and we can come back to those in the question and answer period. For now, though, I will move on, as maybe some folks are typing in the chat box. Let's get to option 3. I'm also being mindful of the time here, and we're just about done, and we'll have about 10 minutes at the end to have a discussion. So this was option 3, accept the parent's continued refusal, but ensure everyone at home is up to date on Tdap, and continue discussion of immunizations at the 9-month visit. Now, this option isn't perfect, admittedly, and to some may feel like too much of a compromise, but the pros are it does continue open and honest conversation, as well as provides the opportunity to build trust with that parent and maybe have them reconsider over time and accept vaccines for their child. And if the parents accept Tdap for themselves, it does some amount of decreasing the risk through cocooning of protecting that child and decreasing the risk of them contracting disease. There are cons, though. I mean, none of these options really are perfect. There's still some amount of increased risk to the child with this option. And if that child does get pertussis, increased risk of transmitting that to others. And it does feel like we're compromising our obligations as professionals to protect not only the child's health, but the community's health. I will admit option 3 is ultimately what I did, and in part for the reasons stated over the last half hour, but also because, you know, we compromise with parents all the time. Other contexts where we might allow parents to refuse high benefit, low risk intervention, like immunizations, given the overall low risk of harm to the child, are those examples there: newborn screening, breastfeeding, vitamin K. You know, though vaccines have an added dimension that's different than these three interventions, namely that they also carry public health benefits, I do think these analogies help us at least think through, like, well, why don't we call CPS when a parent refuses a newborn screen, or decides to bottle feed instead of breastfeed, or refuses the vitamin K IM shot? And that can help us think through, again, risks and harms and where we're at with the particular scenario in front of us where a parent's refusing vaccines. And oftentimes we find we come to realize that we're not at that harm threshold. As I mentioned, vaccines are unique because of the public health benefit, and that may mean that there is reasons to do more than just three, but in the end, what I have found most successful anecdotally, but now more emerging in literature, is educating, persuading, recommending strongly. We should not ever feel like we need to detract from doing those things, but not going so far as firing or invoking CPS except in the rarest of circumstances, as a way to keep an open and transparent discussion with the parent and help them move to accepting vaccines over time. So I'm going to stop there, say thank you for listening, and I do want to hand it over now to Carrie and field questions that any of you have.
All right, thank you, Dr. Opel. I'm going to get us back to our slideshow here, and we're going to welcome any questions that you may have. So just feel free to either unmute yourself or type in the chat box, and we will make sure that those get read. So let's take a look here. We've had a couple of comments too about the firing, or at least one, again from Eric. So he says he's against the firing. However, he has heard from practices in California that dealt with measles cases related to the Disneyland outbreak that they fired patients. Living it makes it real, and firing feels potentially appropriate when you've seen these rare diseases in your waiting room. So yeah, thank you for that.
Yeah, absolutely, and which is why I really feel like I wanted to communicate. I see both sides of this issue. I think you're absolutely right. If you see a lot of vaccine preventable disease coming through your waiting room, and you know, and at the same time having a lot of parental refusal, it does feel like it changes the equation. You know, I also have heard that, you know, practices really have involved their population, their parents, in discussions about this, and many, or a few that I've heard that ended up deciding to only accept those who comply. It really was something that they heard about first from their parents, that they wouldn't feel comfortable coming here without the clinic taking a stance on that issue. And so it does, you know, seem appropriate to, if the clinic leadership is thinking about this issue, to, you know, ask a few representative parents what they think about that, and how the clinic can do this in a way that is respectful but also fair for all patients. Good question.
So Dr. Opel, we have another question. How would you address the ethical issue of a medical provider or medical staff person refusing, for example, the flu vaccine?
Yeah, that's another interesting issue, and somewhat separate, because there are different things that come into play, like employee requirements and restrictions on what employers can do with respect to specific reasons for opting out. For instance, Equal Employment Opportunity Commission routinely peruses these firings, for instance, of employees for wrongful firings because they weren't given equal opportunity. So it's a more complicated issue, and I don't want to go into all the specifics here. But what I would say is there's a few sort of important things to sort of think of from this healthcare employee standpoint. Is, be open and transparent about what the requirements are. It's, I think, reasonable to expect all providers to get immunized, but also to offer alternatives if there is certainly a medical reason why they couldn't get immunized, or a strongly held religious belief, for instance, that they don't want to be getting immunized. I think they have to be given a alternative, and that being a reasonable alternative, if they don't want to get immunized. So there, I think, are important things for healthcare employers to think about as they roll out their mandates for employees, and one of them is offering a fair adjudication process that's transparent, as well as a alternative that is reasonable for that job that employee does, that has evidence behind it to reduce the risk of transmission if they were to get something like the flu vaccine to patients served by that healthcare institution. So lots of things to think through, but that's sort of a beginning way to answer that question.
Thank you, Dr. Opel. Looks like we have another question. Do you minimize the conversation time during a clinic visit with an anti-vaccination family, knowing that you probably won't get very far for them? So maybe just a short variation, of strong message of support, and then moving on to other topics, because as you probably know, it can be very time consuming to get into a conversation with people that they have their strong beliefs that are very opposite of yours. So what tips might you give with those parents?
Really good question. On my first visit with them, if it's a new visit and I hadn't talked to them before about their vaccine beliefs and they express them to me, I do spend some time understanding those myself. Now, if they've been seen by other providers and I'm just sort of filling in and I can read in the chart what those are, I think there is a reason to not spend a lot of time. But the reason if it's the first time I'm hearing about it, spend some time, it's because, I want to understand where they are on the vaccine hesitancy continuum. Are they true vaccine rejectors that have really strong, firmly entrenched negative attitudes and beliefs about vaccines? And if that's the case, you're right, I wouldn't spend a ton. I would try to understand what those are so I can know that, so that when I return to that at a future visit, I can sort of see where they're at with it. And I basically don't spend a lot of time, but I communicate. I appreciate you telling me about those. I'd really love to, talk about them again when you come back, but we don't have to talk about them any further now. If it's somebody who's on the fence, or what they're concerned about is, something that I can clearly and easily address, misinformation, a myth, whatever, part of the reason I spend some time is so I can make sure there's not an easily addressable thing there that might be enough to just get them off the fence. I mean, some of my own empirical work has suggested that not spending a lot of time on those times when a parent just brings up that they don't want to do it and kind of just moving on can miss a fair proportion of parents who are just on the fence. And while it sounds like they're really firmly entrenched based on how they're saying they don't want the vaccines, and if you were to, explore a little bit more, it becomes apparent that they're really just on the fence, and something you say or can address may get them off the fence. Now, clearly that's not the case for everybody, but part of the reason I spend some time to uncover where they're at and what they're concerned about is because I do want the opportunity to push back and provide some reasons why, to address their concerns to see if I can get them immunized. But that's how to answer that. I think if you have a vaccine rejector, you do not need to spend a lot of time. Really just try to keep them understanding sort of the fact that you want to keep having an open, honest conversation with them and talk about this at future visits.
So one more question, Dr. Opel, kind of along those same lines. Can you talk just briefly about how you handle it when a parent does ask for an exemption to be signed?
Yeah, this is a good question, and especially given the change, as we talked about with MMR. The change that went into place that requires a provider signature, which was, I believe, 2012 or so, requires us to sort of have this discussion about risks and benefits and why they're, of remaining unimmunized before signing this. And it was meant to promote a discussion to ensure the parent feels informed in their refusal. And if a provider feels comfortable having that or already had that and sees that signing this form will, keep the parent coming back to them and talking about vaccine issues and getting the care otherwise non-vaccination related that they feel the child needs, I think providers should feel comfortable signing that form. If it's a parent you hadn't seen before and they're new to the practice and that's the first thing that they're coming to you with, I think it's also appropriate to push the pause button and not immediately just reflexively sign this. Get to know the parent and, and I would also say there is no reason why you have to sign that you're not mandated as a provider to sign these forms. Now, that might mean that the parent goes somewhere else and you never see that parent again. So if it's somebody for other reasons you do want to keep in the practice, I certainly think it's appropriate to sign, but I also just want to make sure providers know that it isn't a mandate that you sign this. And if you feel like for whatever reason the parent is shopping around that form or is, giving reasons that you feel like, you can't even engage them on, or they don't want you to talk about risks and benefits, you do not need to sign that form. So in general, I sign them, but I always have a discussion. I don't generally like my nurses to just send me a staff message over our EHR saying, can you sign this? I often want the parent to come in and talk to me so I can have a face-to-face conversation with them.
All right. Well, thank you so much. That brings us to the end of the webinar. We thank Dr. Opel for sharing his research findings, his experience and insights related to working with parents who refuse to vaccinate or perhaps opt for a modified vaccine schedule. Once we have the recording available, it will be shared with you as attendees. And before you go, if you would please click on the link in the chat box to complete a brief survey. If the survey isn't working, we also will be sharing it out in the email that we send you with the recording. So don't stress out if it doesn't work for you today. So we'll keep the webinar chat box open for a couple of minutes in case anyone has any other comments or questions. And from Betsy, Kylie, and I, we thank you and have a great rest of your day.